Okay, so hello everyone. So it's a pleasure to be here. I'm sorry I'm here because of a report that it's a bit scary, but I've never been in New Zealand before, so it's my first time. I'm very happy to be here. So my goal here is to tell you a little bit of what we are fighting for in the ABC Global Alliance, and probably also extrapolate to what should be your priorities in what you need to fight for here in New Zealand as well, adapting to your current situation. So I apologize for the photos, but I wanted to put this first slide to tell you what is advanced breast cancer, because there is sometimes some discussion. Should we use the word advanced? Should we use the word metastatic? What is the best way to use it? And the reason why we chose in our work advanced, it's because it comprises two things. One is that you see here in the images of, let's see if I can point, of these PET. So over there you have images of a PET CT, and you show that they show, one shows liver metastasis, the other shows bone metastasis, and this is metastatic disease. So we have disease far away from the breast in many organs that it can affect, and that's also called stage 4. Unfortunately, in the UK, they also call it secondary. I say unfortunately because I don't think it's a good name. First, it seems like it's second to something. Then it means that it's always recurrent, which is not the case. You can be diagnosed with stage 4. So I don't think the word secondary is very good. But then there is another group of patients which are called the locally advanced breast cancer. Really very, very locally advanced. You have some photos here and also images of MRIs that show you that the breast cancer is still in the area of the breast and the axilla, so the armpit, but it's very big and it's not operable. And this is a situation where in a developed country is more or less 5% of cases. But in the developing countries, this can be the usual presentation of breast cancer. And I teach around the world, in Latin America and Africa. This is the most frequent way of being diagnosed with breast cancer. Now, this very, very locally advanced can be at diagnosis, but can be also recurrent. So the recurrence can be in the skin that surrounds the breasts. And this is a situation that most people don't know where to put these patients, because they are not really metastatic, because the disease has not spread out, but they are not early breast cancer either, and so they are a bit lost. And that's why we decided in our effort, instead of calling metastatic breast cancer, to call advanced breast cancer, to include both of the clinical situation. Now, the other thing, very, very important, and this is probably the most important message for the clinicians when we are teaching them. There has to be a change of mindset, because the goals of treatment for this situation are different than when we have an early breast cancer newly diagnosed. So for the moment, the disease is incurable. It doesn't mean that it's not treatable. It's treatable, can be treated for many years, but for the moment, cure is very rarely achieved. And because of that, what we want to achieve with our treatments is that we want to improve survival, obviously. However, we don't have that many treatments that improve survival. We have to improve on that as well. And we have really to have access to those few that improve the survival. And then we want also to delay progression, prolong the duration of the response, take control of the symptoms, and improve or maintain quality of life. And one day, probably transform this disease into a chronic disease. We cannot say, sometimes people say, oh, in many situations it's already a chronic disease. Well, a chronic disease by definition is a disease that you can live 10, 20, 30 years with it, right? It's not yet the case with this disease, but hopefully one day it will be. So this balance between quantity and quality of life is very, very important here when you don't have on one side the perspective of being cured. When you have a perspective of being cured, probably you accept much more toxicity also because the treatment will be in a limited period. But here the treatment will be prolonged for a long period of time, and you must have this balance between quantity and quality of life. Now, I started this work many, many years ago because coming also from patient advocates, there were two very important presentations in 2006. One, it's called the Bridge Survey, and the other one is called Silent Voices. So what did this work showed? Showed that patients with metastatic disease felt that they were being abandoned by everyone, by the physicians, the researchers, the media, but also they were being abandoned by the patient advocates, because everybody was so focused on the pink movement and on messages of screening and early detection, and that if you live well and eat well and exercise, everything will be fine, and that is not always the case, right? They also felt guilt because they say, okay, if I do everything right, I will be fine. Then if I'm not fine, maybe I did something wrong, and maybe it's my fault that the cancer came back. So a lot of these guilty feelings would appear, as well as isolation and loneliness and difficulty of speaking about the disease, even with family members and friends. And because of these, I try to do something about it. Because always when I see something that's not well, I try to say, why can't we do something about it? And this is why we decided that we should create guidelines. Guidelines are recommendations. And when I started, and I know that this is the argument of some people in New Zealand, so I will say what I was told back in the days, is that no way I could make guidelines for advanced disease, because guidelines are very nicely done for early breast cancer, but in the metastatic setting you can do whatever you want. And it's very hard, and every patient is different, and there is no way you can get guidelines done. And I thought that was a very lame excuse. And I said, no way, I think we can do it, and we don't need to discuss if you like more this drug or that drug or this company or that company. That is really not the case. It's more the principle. How do you treat this disease? And how should you treat it? And so we started by creating a small task force, and the first publication we did was 12 principles on how to treat this disease. Very simple things, but things that are not done in many parts of the world. And then we took each of those principles and developed it further, revise all the available literature and issue some recommendation. But it was taking a lot of time, because we asked for one of the breast cancer conferences to give us some time to have a discussion about the guidelines and presentation. And you know what? At that time, nobody wanted. So they told me, I don't want to be linked to metastatic disease. I said, okay, if that is the case, I'll create my own conference. So we went on and created the ABC conference, and this was the first ABC conference that was in 2011. And the objective of this conference is that you revise all the available literature, and then that you issue recommendations, and then obviously you need to fight for them to be implemented. You can have beautiful guidelines, but if they are not implemented, they won't change practice, right? So we've been working for many, many years. These are just photos of the different ABCs. What you see there is the last day of the conference, where the top experts in the world for breast cancer vote on the different recommendations. And then based on that, we write down the guidelines and we publish them. And you'll see that the number of the experts is increasing every time. So that's the last one. And the next one will be this November, so it'll be ABC5. And we already had last time 1,300 people coming from 88 countries just discussing metastatic and advanced disease, nothing more. And then the members of the panel, and particularly myself, we go around the world explaining these guidelines and also working with our colleagues to be able to adapt these guidelines to the different countries. You have your own accessibility problems here in New Zealand, but unfortunately you are not the only case. There are many problems around the world, many countries where access is a problem. And when I say access, it's not just access to drugs. It's access to the whole infrastructure that is necessary to treat advanced disease. In some countries, it's even access to oncologists. They simply don't exist. And what I'll show you now, and these are also two pieces of work that are freely available and are very useful. So this is the report that it's called the Decade Report. So this one here is the Decade Report. So it was a work done by the European School of Oncology with the support of Pfizer, where we look at 10 years around the world except the US, because they did their own report. You know, America first is always separate. No, I'm kidding. But this look at what happened in the world for 10 years around metastatic disease. And I think your report was inspired by this one. And then there is another effort which was called a campaign sponsored by Novartis called Here and Now. They also collected very important feedback from patients. And I always present this slide and say that two of the most important work done in this field were done because of the support of pharma companies. And sometimes people, because of access, always look at pharma companies as being the enemy and being the bad guys in the picture. And they are not always the bad guys. Sometimes they are able to do good things also. And sometimes the ones that are supposed to be the good guys don't help us. So along this journey, I've learned that there is really no good guy and no bad guy. Everybody has a little bit of both. So you just need to take the good out of each one of them. So what did the report show? So the report showed that things have been changing, but so slowly and so desperately not good enough yet. So what you see over there on top is the percentage of people who are alive at 5 years. And here in this square, over here, you see the results for metastatic disease. And you see that from the 90s and until the first 10 years of the 2000s, the only thing we were able to improve was from 23 to 25%. So if that's all that was able to be done in a decade, how long it will take for this to really improve, right? And the other columns are the percentage of people who have early breast cancer and are alive at 5 years, which obviously is much, much higher. And then the report also looked into quality of life. I told you there is a balance between quantity and quality. But what you can see is that despite an early improvement, if we compare from 20 or 30 years ago, quality of life is much better now. But then the last decade, if anything, it even decreased a little bit. So there was also not an improvement in quality of life. So this got us to us thinking, what is happening? So why these things are not moving faster? And then I put this one here because, as I told you, I'm sure it came out of also inspired by the Decade Report. And this shows what for me was a very, very sad surprise, I must say, because I always considered New Zealand as a very developed country. But I'm afraid that the results that we see in the outcome of advanced disease are not from a developed country in New Zealand. We will discuss a little bit more later. So some points that this report highlighted, the decade report, but I'm pretty sure it also covers New Zealand. So there is still a lot of lack of knowledge from the general public, also from politicians, sorry, from policymakers about what is really advanced disease and advanced breast cancer. And there are two types of attitudes regarding the advanced breast cancer. One is that attitude that says, oh, it's breast cancer, so it's pink and everything will be fine, and just focus on early detection and that's it. And then there is the other opposite that says, this is an incurable disease, so why bother? So why investing? It's incurable anyway, so let's just give up. And these two attitudes, two extreme attitudes, are both wrong and are both hurting the patients, and you know that very well. So what the report shows is that we still have to fight against this stigma, because it's neither one situation nor another. It is true that it's not yet curable, but it's certainly not something that we need to give up, and we can live many years with good quality of life when treated properly. Perhaps one of the most shocking findings of the decade report was this one, and it's a complex slide, but basically what it shows is from all these countries that you see here, and they go from well-developed countries to less developed countries all over the continents, you see that the majority of people, well, I would say the majority, 1 out of 4 or 1 out of 5 people believes that metastatic patients should not speak about their disease, except with their own oncologist. So meaning that people don't like to hear a sad story, let's say. And they assume that because someone has metastatic disease that they have a sad story, which is not true, right? Just because you have an incurable disease doesn't mean that you cannot have a very positive look on your life and a very positive story. So we wanted to change this, and this takes a while. So changing mentalities and knowledge takes a while and takes the effort of all of us together, and it will take a lot of time, but I think it's much better now than it was when we started this. I will show now some general recommendations of the ABC guidelines that are very obvious, but it doesn't mean that being obvious they are followed. So one of them says that we need to discuss in a correct way, but also in a truthful way, what are the goals of treatment with the patient. And the reason why we say this is because it's not uncommon that someone reaches the end of their journey without knowing that they have an incurable disease. And that's not good, because you should be able to adapt yourself slowly, progressively, and not then all of a sudden someone tells you there's nothing else we can do. So we need to be truthful. It doesn't mean we need to be cold and blunt, but I don't promote as well, and in my country it happens a little bit less now, but it still happens that you don't tell anything. And the family says, please don't tell anything. And that's not correct. I mean, people have the right to know what they are facing, what are their chances, without lying. But this has to be done also respecting what everybody wants to know, and not assuming that every single patient will want to know the same amount of information. Everybody is different. Some want to know everything. Others already tell you that they don't want to know all the details. And then we also recommend that everybody has, from the very beginning, psychosocial support, supportive care. Supportive care means, for example, treatment for nausea and vomiting, or treatment for other types of symptoms, as well as control of pain, right? And that this must be there and present from the very beginning. Even if in the beginning most people don't need that much, it is important that it's already there and that everybody knows it's available. And then finally also in these general recommendations, it says that the patients must be actively involved in the decisions, and that the decisions should not be taken by the physician assuming that they know what the patient wants. Because I told you again, every patient wants a different thing, and we cannot assume. So very often, or we frequently recommend that people don't come alone to the appointments. Because for early breast cancer, many of the appointments go quite well and quite fast. But in the advanced setting, they may go quite well and quite fast, but you may also have the news that the disease is progressing again, that you need to change treatment, and you need someone else with you that could listen to all the information. Because once you hear someone tell you your disease is progressing, everything else that the doctor will say, you will forget about it after that sentence, because you will be in a stressful situation. So all these recommendations seem very simple, but they are very important that they are implemented and done. But then when we go to the report, what does the report show us? They showed that less than 50% of oncologists actually had training in communication. So I just told you that we need to know how to communicate, and we are not trained to do that. Okay, some of us look for this training in communication elsewhere, but we should be trained in medical school, and we should be trained in our oncology specialty, but we are not. And some of us do it well, some others are not that good in communicating. Then the report also said that patients are not very often telling what they want. So the communication goes both ways, and it's difficult both ways. So even though we say that the patient should be actively involved, only half of them want to be actively involved. So how do we change this part here as well? And I think the work that the Breast Cancer Foundation is doing in New Zealand and the work of many patient advocates around the world is also educating that you need to be involved and you need to be able to talk about it. And then lastly, we recommend that these discussions about when the time comes and the end of life comes, how do you want things to be done? Do you want us to go treat up until the end? Do you want to stop? All these very, very difficult discussions should be taken when you are good, not when you are there already. Because when you are there already, those are even harder to discuss. And yet the report shows that 65% of these discussions actually are done when the moment is there already. And this is what we want to avoid. Nobody likes to have these discussions, but it's part of our, let's say, job of being an oncologist to be able to discuss these issues. And so, because things have not changed that much, and we're taking such a long time to change, that's why we wanted to create something that can help through around the world all the patients that have this disease, and that's why we created the ABC Global Alliance. And I guess what shows that there was really a need for this is that we created the alliance, and I would say every week we have someone joining us. So we already have 147 members from 82 countries, covering almost everyone in the world, even New Zealand, look. And the reason to create this alliance, it's basically to give a place for anyone, any type of stakeholder, patient advocates, patients themselves, physicians, researchers, pharma companies, cooperative groups, policymakers, anyone who would like to do projects for the good and the benefit of advanced breast cancer patients. And obviously, we've been working already quite a lot, and I don't have time to show you, but it goes from lobbying. For example, in Europe, we lobby a lot at the European Union, but in each country you need to lobby in your own politicians and policymakers. There are other things that we can do at a broader level, others that you have to do at your country level. Educating the public is something that you can do using all the online and social media forums that exist. But there are other things that you need to do hands-on. So for example, with our friends and members in Australia, we are helping hands-on Timor-Leste. And in Timor-Leste, I know you are worried about what you have in New Zealand, but in Timor-Leste they have nothing. Nothing is the term. No pathologists, no oncologists, no nothing. Everybody has a mastectomy, even without a biopsy. It's terrible. So we've been doing some hands-on work there to help the patients there to have a better outcome. And so the first thing we did in the Alliance was to create this global charter. It took a long time, but it was kind of a needs assessment. What can we do in a 10-year period that is feasible and measurable? So it's not a wish list. Otherwise, I would have put there cure breast cancer. So nobody put there cure breast cancer because it's not feasible in 10 years' time. But what we put there, and you can read them carefully, these 10 goals are things that can be achieved and are a list of priorities of what you can aim. And this charter is being translated in many, many languages and is being used in each country as a priority list. And when we say the first one is double the survival by 2025, obviously your level from where you start is different. So now you have a report that shows you from where you start. And you need to aim that your medium survival is the double in 2025. And if you can achieve that, it's already a huge step forward. And then I'm not going to go into the details, but all of them deal with improving communication, improving information, allowing people to go back to work, knowing more about advanced disease. Any questions from anyone? Breast Cancer Foundation has joined us.
Ah.
Yes.
Okay, cool. Thanks.
It's a whole mix of everybody. And actually the first, let's say that the first ones to get more together were the patient advocates. So the physicians have now started, and the societies have now started to join as well. But mostly in all the different countries were the patient advocates that started. For the moment, yes. But who knows? Maybe the Society of Oncology can join. Yes. When I look at the report, clearly there is an issue of funding and access to treatments, to certain types of treatments, but I don't think it is only that. I think there is a change in mentality that is necessary, perhaps on everyone, the patients and the oncologists, because when you see the lines of treatment that people receive here, so you have a very low number of lines on average, just 2 lines. So let's say that it's very common that a breast cancer patient gets 7 lines of treatment, okay? And that's independent of the subtype. But obviously for some of the subtypes, it is even longer. Let's say the ER positive, the hormonal dependent, they get even longer lines because they have endocrine therapy and then they have chemotherapy. The triple negatives are the ones who have less because all we have is chemotherapy, and at a certain time we are out of options. But the HER2 positives and the ER positives can have many lines of treatment. This disease is very difficult also from the emotional perspective because it is a disease with ups and downs. So you start a treatment, and the treatment is controlling the disease. And it lasts for a certain number of months or years. But then the disease wakes up. And this is because the cancer cells are intelligent and learn how to grow even in the presence of the treatment that you are giving. So that's something we call resistance. So the cells become resistant and they start to grow again. So what you need to do, stop that treatment and give another one, right? One that it's not expected by the tumor cells, and then they go back to being under control. And this is up and down. It is very emotionally tiring and stressful. And then sometimes people might say, oh, I have chemotherapy, but it didn't work. Well, it did work. It's just that it worked for a period of time. And so maybe the perspective of it didn't work has to be maybe, we have to focus more information about that. It's not that it did not work. It did its job for a certain amount of time, but then it won't work, but there are others that you can continue to give. And I'm not saying it's easy to go up and down, but it's for the moment the natural history of this disease. So I'm not going to go and discuss individual drugs because I have my own view on that. And there are certain classes of drugs that have a proven efficacy in terms of prolonging survival. And those are the anti-HER2. So trastuzumab, pertuzumab, TDM1, those are, and I'm saying the names because there are no competitors there. So they're only the ones that exist. And those have shown to improve survival in a substantial way. And that should be your priority, to focus on the drugs that have shown a substantial benefit in survival. Then there are other drugs that have not shown this benefit in survival yet, but have shown a longer control of the disease. And the one that you mentioned, that is palbociclib, it's one of the CDK4/6. There are others, so I need to tell the other names. So ribociclib and abemaciclib, all of them shown a very good control of the disease, but they have not yet proven beyond doubt that they improve survival. So I put them in your second priority, right? And what we try to do with the Alliance is we cannot solve the accessibility issues of all countries, but we try at least to help with what we call resource stratified guidelines, to tell you what should be your top priority, your second priority, and your third priority. And then it's up to you. Say, we have money only for the top ones, or we have money to go down. And there have been a lot of efforts. So for example, from the European Society of Medical Oncology, we've created a scale. It's called the Magnitude of Clinical Benefit Scale. So what does it do? It looks at the trials and classifies in an objective way the benefit that each treatment brings. So it's really a scale that goes in the metastatic setting, goes from 1 to 5. And the ones that reach 4 or 5 are your top priorities. And there are many governments and many reimbursement bodies in Europe that are using the scale. And so they start by funding the ones that are 5 and 4. And then if they have more money, obviously some countries can fund also the ones that score a 3. And it's useless to fund those who score 2 or 1 because it's a waste of resources. But it's the ones that scale 4 and 5, it's not fair that they are not available for all patients, right? Yeah, so I don't know exactly why quality of life has not been improved. I have 2 points on that. So one is that we are not measuring quality of life properly because the quality of life tools were developed for early breast cancer and were developed for early cancer overall. So the measuring quality of life in advanced disease has to have other tools that are developed specifically for metastatic disease. This is what we are doing. We are developing now with the ORTC a tool that it's really more useful for the metastatic setting. Many of these new trials had quality of life measures, and then in the end they say there was no difference. But when we have the experience with the drugs, we know there is a difference because we see. So why the tools are not picking up that difference? Maybe I think methodological, there is an issue there. The second reason I think is because obviously not here in New Zealand, but in many other countries, there is an excess of chemotherapy. So we have many options for ER positive disease that are not chemotherapy driven. But somehow people are still focusing too much on giving chemotherapy. And then obviously chemotherapy has more toxicity than endocrine therapy. And that has also an impact in quality of life. So 2 points there. I believe that we cannot be happy with what you are saying, progression-free survival only. I'm not saying that progression-free survival is not important. I'm just saying that it cannot be the only aim. Otherwise, we just improve 2%. So progression-free survival, so just to explain, it means the time you live without the disease progressing. But it doesn't always relate to the time you live, so to the overall survival. Sometimes it does, sometimes it does not. But if I have a drug, let's give a very blunt example. If a drug gives me 4 months benefit in progression-free survival, but no benefit in overall survival, what does that mean for a patient? It means that unfortunately my day of death will be the same. It's just that there will be 4 months where the disease will not be progressing. Okay? Does that have an impact? Maybe. So if the disease progressing gives you symptoms, then if you avoid the progression, you control the symptoms, you have a better quality of life, and that matters, right? But in breast cancer, many times, the progression of the disease doesn't give you symptoms. Let me give you an example. So you have a liver metastasis that is 2 centimeters. Even if it grows for 4 centimeters, you still don't have symptoms because the liver is a very special organ, and you need to have more than 70% of the liver afflicted by the metastasis so that it doesn't work properly. But so 3 centimeters, 4 centimeters, it really doesn't matter. So the disease is progressing, but you feel the same. So in that situation, what you want is a drug that improves survival, not progression-free survival. So I was explaining to Adele that some countries are being innovative in some ways. Like they are accepting a drug, an approved and funded drug, based on a progression-free survival benefit, but temporarily. And they tell the pharma that, okay, you have 1 year to show me that it also improves survival, or if it doesn't, you have 2 options. Either you decrease the price or you lose the approval. And I think that is fair because we cannot be willing to pay a huge amount of money for a drug that only improves progression-free survival, or the same amount of money for that drug than for a drug that improves survival. I think this is a fair deal and say, okay, if you prove to me that your drug is really impacting on survival, you can sell it for this price. If not, you have to reduce the price. Germany is doing that. In terms of the time that we need to get the survival data, we don't need 20 years in the metastatic setting. It's true that we need that time for the early setting, but in the metastatic setting, because the medium survival is shorter, you don't need that longer time. But unfortunately also, because the majority of countries, and particularly FDA and EMA, approve drugs even for small differences in progression-free survival, companies are not putting the effort that they should in designing the correct trials and the powerful trials to show survival benefit. Palbociclib is an example. So the trial of palbociclib showed a survival benefit, but it was not statistically significant. Why? Because they did not want to make the trial a little bit bigger. All they had to do is to include a little bit more patients, and then we would get the answer if yes or no. And then the drug would scale 5, and there will be no discussion that it should be top priority. Let me make now 2 or 3 points about some of these goals. So you see here that one of these goals is, number 2 says, enhance our understanding about ABC by increasing collection of high quality data. And you saw what you can do if you have data. So the report is what is a beautiful example of what you can do if you collect the proper data. But when we look at the global statistics, and all this is available freely also in a site called GlobalCan, they have the latest numbers for all cancers. And you see here, these are the numbers for last year, that currently around the world there are over 2 million new cases of breast cancer every year. So 2 million women in this case are diagnosed with breast cancer. About over 500,000, so 600,000 die every year because of breast cancer. And then if you look there in the GlobalCan and ask how many metastatic patients exist, you can't find that data, because the majority of cancer registries are not registering relapse. So you don't know. You know something else, that it's called 5-year prevalence. And this means that someone who had a diagnosis in the last 5 years and is still alive. But this can be all the survivors of early breast cancer, so they had a diagnosis, they went through the treatment, and they are well now. Or can be someone who is living with metastatic disease. We don't know. So among these, almost 7 million people who are living, having had a diagnosis of breast cancer in the last 5 years, we don't know how many are metastatic. We can make a very, very rough calculation, because it's usually 1/3 metastatic for 2/3 early. And you would say, well, maybe 2.2 million will be living with metastatic disease. But I don't know if this number is correct or not. De novo is sometimes collected, because in some cancer registries, since they collect the diagnosis and they collect the stage at diagnosis, they will know which ones are stage 4 at diagnosis. But they will not know who had previously and then relapsed. Okay? And in GlobalCan, they don't give us the results per stage. So I cannot tell you how many stage 4 that includes. Okay? So we've been talking about this for a long time, and some countries have done a very good job. So one of them is Germany, the other one is France. I'm showing you here the registry in France. This is not the full French population, but 16 major cancer centers who got together and collected data on metastatic disease. And so this comprises almost 20,000 metastatic breast cancer patients. So it's a very substantial number. What do they show us here? They show the survival. Let me see. They show the survival from the different years. So those who were diagnosed in 2009 until those who were diagnosed in 2013. And you cannot really separate the curves, right? They are all overlapping. And you have here at the bottom the reason why. So the median survival from all these years, it's all around 3 years. A little bit less, a little bit more, but around 3 years, right? So again, like I showed you in the beginning, not a lot of improvement in this last decade. Then this is the other register from Germany. And what they show here is survival according to the subtype. And the one that is very bad is this one here, is the triple negative, where we haven't seen a lot of advances. But where we see most advances is in the HER2 positive. And this is one of the reasons I already explained to you. And then, this is maybe for your question about de novo or recurrent. This is data that was done by a group of also patient advocates together with some epidemiologists in the US. But you have to put this into perspective, meaning that this comes from a center where they have access to everything, okay? So why am I saying this? Because they show that the de novo metastatic patients have a very good median survival of about 5 years. They have access to everything. But those who have a recurrent, they have a median survival that's even inferior to the average. The reason why we are dealing this more and more is because in this center, they give all the best treatment in the early setting. So they have very, very high rates of cure in the early setting. But those who relapse are those who are really the bad tumors, the tumors that are resistant to everything. This situation here is not, we cannot translate to everybody in all over the world. Depends really what you are giving also to your early breast cancer patients. But as a rule, if you have a de novo cancer, it is less resistant to therapy than a recurrent, because a recurrent cancer already received some treatment in the early setting and it still was able to come back. So there is some resistance already. And sorry this doesn't project very well, but this comes from your own report. And I showed you the median survival, like in France and in Germany, and I showed you it's around 3 years. And here you see the median survival in your country, that it's clearly, sorry, I can't see, that it's clearly below that. So it has been improving from 10 to 18, but still below the median in other countries, other developed countries. And for me, where was very particular interesting to see is that the one that has been improving the most in other countries is the one who has a very low survival in your country, which is the HER2 positives. Obviously, the triple negative has a worse result, but the HER2 positive is where we see the biggest advances in other countries. And in your case, that's really bad. It's about 1 year only. So here, I think, has to be the priority, because it can easily be improved. Even if you cannot have access to all the drugs that exist, the first thing you should fight for is that you must be able to continue to receive trastuzumab or Herceptin beyond progression, because it helps control this disease. And already that would be a big step forward. And then obviously have access to the other drugs that block this type of cells. From the German register, we also learned one thing that is interesting. So here, what we show here is the distribution of the subtypes. And initially, we thought that maybe in the metastatic setting, the triple negatives would be much more frequent because they are the most aggressive. So maybe we have them more in the metastatic setting, but that is not the case. The distribution of the subtypes is very similar in the metastatic setting and in the early setting, meaning that the ER positive, the hormonal dependent cancers, are still the most frequent, even in the metastatic setting. So my take on this is that if we get a drug or a class of drugs that impacts survival in this very, very frequent subtype of breast cancer, we will be able to pull the medium survival up. Okay, so we have high hopes that the CDK4/6 inhibitors, palbociclib and ribociclib, might be the drugs that do this. We don't have the data yet, but we have high hopes that they could be the ones changing this. So I wrote this editorial quite a while ago, looking into the reasons why guidelines are not followed. And some of the reasons are because of reimbursement rules. And I don't know how many of these apply in here, but in many countries, the funding bodies do not pay you unless you use the day hospital. Okay? And so meaning that everything that it's oral, and you don't need to go to the day hospital, they don't want to fund. And so they kind of indirectly push the oncologist to prescribe an IV treatment. And that is not more convenient. Sometimes it's more toxic. And so the funding pressure or the funding rules are not very patient-friendly in many of these countries. And this is very, and if you ask me why are this way, I don't know how to explain. Because everybody loses and everybody would win if they would do it otherwise. Because we would save money, so the governments will save money. It will be more convenient for the patients. You can waste least resources like nurses and everything, but I don't know why it's not changed. We keep talking about it, so maybe one day we'll manage to change this. I'm going to skip this, and I'm going to speak, well, maybe we already spoke a lot about the financial impact of all these things. And what I might want to tell you is about this, and I'm sorry one part of it is written in Portuguese, but it doesn't really matter. I just wanted to show you a work that was done in the University of Lisbon, but there are plenty of these works done in many countries, and these are called the indirect costs of cancer. So not the direct costs of cancer medicines and all the treatments, but the loss in productivity. Because cancer affects people when they are in the most productive years. And so most of people have to stop working, because in many countries you either work full-time or you have to be on sick leave. I don't know here if you have flexibility in your work laws that allow you to work part-time or allow you to work from home. But in the majority of countries that does not happen. So you're either fit to go to work 100%, or you have to be on sick leave. And what you can see here is that the indirect costs this is a study that looked in treating breast cancer only in 1 year in Portugal, which is a small country, 10 million people. And the direct cost was 146,000 euros. The indirect costs, 163,000. Giving a total of almost 310,000. But you can see that the indirect cost is higher than the direct cost. So if we want to save money, and we all want to save money to have more access to treatment, we can start by changing the laws of work, because the majority of patients tell that they either are not able to go back to work, or even if they try, they leave work in less than a year because they don't have this flexibility. And then they have financial problems as well, because if you are on sick leave, you're not earning as much as if you are working. So one of the things we're doing is to fight for this change in the work laws and in the application of these changes. Some countries have changed the law, but they did not make it mandatory. They leave it to the decision of the employer. Well, the employer might not be willing to decide like this. So one of the things we did, we went to the Parliament, to the European Parliament, to start from there, the change in the laws of work. And now we have to take these to the individual countries, because each country has their own law. So this is something that I want to show you just one thing. So you don't need to read, you just need to look at the colors. At ESMO, in the European Society of Medical Oncology, we did a survey around the world about true access to medicines. Not just the ones that are approved, but the ones that you can have access, either freely or full cost. So the ones that this is around the world, and there is New Zealand. We don't have a lot of data on New Zealand, but this one we had. This is trastuzumab, and then the other are other anti-HER2 agents, lapatinib, pertuzumab, T-DM1. If it's blue, you have freely available. When you have a lot of red and black, it means that you either don't have it or you have to pay full cost. And you can see here that the lower you go, obviously, in the country, the more black and red you have. But still, in some of the high-income countries, you have a lot of reds, including in New Zealand. As you can see, all the others are red. The other problem is the use of trastuzumab in the metastatic setting, which is what you have as a problem. You can only use it twice, one in the early and once in the metastatic. And you can see here, around the world, there are a lot of reds also. And I don't have any data. In these maps, there is no data for New Zealand. So all we have is the data for Australia, which I suppose is different from here. But for example, T-DM1, even in Australia, is not available except at full cost. And lastly, two other drugs that are very, very important, which are pertuzumab and fulvestrant for the ER positive, also not available unless at full cost. And I'm assuming the situation here is the same. One of the things that you can do is to push for biosimilars. So trastuzumab now has biosimilar. The biosimilars that are approved by FDA or EMA are of good quality. You don't need to be afraid for that. And it reduces the cost of Herceptin, for example, in about 30%. So it's a good option also to have them. And so the recommendations I brought here are the ones that I think you should fight for. One of them is that metastatic patients are discussed in multidisciplinary teams. And this is not done, and not done in many parts of the world. So people are, I think, convinced about discussing early breast cancer cases, but not the metastatic breast cancer cases. And this is indispensable so that the best treatments are given to each individual. Then I already explained to you the problem of tumor resistance. Remember what I explained about control of the disease, and then they grow again, and then you change the treatment, and then it goes on and on. So what we need to do is to get a good information about the biology of the tumor in these different phases, meaning that we should take biopsies at these different phases. Or maybe in the future, we will be able to use something that we call liquid biopsies, that are tests done using the blood instead of doing a biopsy, which is an invasive procedure, right? In the more distant future, we can use techniques of imaging, of nanotechnology to avoid the biopsy. But so far, what we have is the biopsy. And if we take a decision based on what the tumor was in the beginning, as you can see here from the figure, the tumor is very different after 2 or 3 lines of treatment. So that's why we advocate that a biopsy must be performed at least once, and especially when the disease is easily to be biopsied. And also we need to reassess the receptors, the hormonal receptors and the HER2 receptors. There is one problem with bone disease. Sometimes bone is not the best place to do a biopsy, and sometimes the oncologist might say, not now, we can wait for later if there is a lymph node or another type of metastasis, because the bone is hard to analyze. Now for the most frequent type of cancer, the ER positive cancer, this is the most important recommendation, the one that all guidelines agree, and the one that is not followed by many, many oncologists around the world. And sometimes it's also because the patient does not want. So, meaning what? In the hormonal dependent cancer, the most effective treatment is hormonal therapy or endocrine therapy. But because it is a pill that doesn't have that much side effect, some patients say, I don't want to take it, I want something stronger to control my disease, which is wrong, because for this type of cancer, this is the type of treatment that works the best. It's endocrine therapy. Even if we have what we call visceral disease, meaning liver or lung, important organs that have the disease, but endocrine therapy is the most important type of treatment. And the way we treat, or the way it should be treated, this type of cancer, is with multiple lines of endocrine-based therapy. And that's why it's so important to have access to all the types of endocrine therapy. So we have tamoxifen, we have the aromatase inhibitors that are letrozole and anastrozole and so forth, and we also need fulvestrant in these options of treatment, so that we have many lines of endocrine therapy before we have to move for chemotherapy. And I had this to show you. This is from the Netherlands, but to show you that even though everybody says yes, 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 you are right, they go home and they prescribe differently. Because the percentage of patients with this type of disease that receive chemotherapy as the first option is very high and should not be. It should be endocrine therapy. And actually, with all the difficulty in methodology of this study, it shows here that if you start with endocrine therapy and leave chemotherapy to the end, you have a better survival. I put this here just to remind you, to tell you, I don't have time to go into the details, but young women, I see some of young women here, but young women who have metastatic disease have in many parts of the world less options, because the majority of trials were run in postmenopausal women. And the way we are fighting now is that the first recommendation for a young woman that has advanced disease is to become menopausal. So we either remove the ovaries or we give an injection that puts the ovaries to rest. So that's the first thing you should do. So once you do that, why cannot the woman have access to everything else? Because it became menopausal, right? But in many countries, the funding body says no, because the approval is postmenopausal women. And so this is something we're trying to change, both in the clinical trials and also in the access in real life to all the treatments. Last point about when we need chemotherapy. When we need chemotherapy, we should favor to use one treatment at a time instead of giving too many treatments together. And from all the different types of chemotherapy that we have, we should focus on the ones who have a better toxicity profile, meaning that they have less toxicity. Because unfortunately, they are not very different in their efficacy. They are very, very similar. And so the way to choose is more on the side effects. For some people, they may want to avoid losing their hair. For other people, they want to avoid numbing or tingling in the hands and feet. So each person may have different needs in terms of avoidance of side effects. And so we can choose. But the most important thing is to use just one drug at a time and not a combination of drugs. And this is a slide I use to teach young oncologists, saying, if your goal is to treat for as long as possible with the best quality of life, there are a couple of things you should not be afraid, like reducing the dose until you find the good dose for that individual patient. Prefer oral drugs instead of IV drugs. And as I was trying to explain, discuss with each patient what is the worst side effect that you want to avoid. And then, because some of you asked about some of these, when we are trying to focus our resources in what is really important, we should not waste it in things that have not proven their value. And some of the things that have not proven their value in metastatic disease are these multi-gene panels, also called next generation sequencing. So you now can go online, and all these companies are trying to tell you, send me a piece of your tumor or a saliva, and I'll do this test and find out all the genes, and I will tell you what is the best treatment for your tumor or for your disease. You can find this online, several of them. None of them is valid. None of them have been validated. And just so everything is business, right? And for a person who is desperate with an incurable disease, you are vulnerable to what can be sold by different companies. And so we are trying also to get some more legislation on what can be sold online. But any of these type of tests that tell you, I will tell you the alterations of your tumor and you can choose your treatment based on that, none of that has been validated, and it's not for use. It's a waste of money. The same for now in terms of circulating DNAs, a lot of things coming out on liquid biopsies. We believe one day we will get the correct methodology, but for the moment it's again a waste of money. And immunotherapy for metastatic disease for the moment is also not something where you should spend your money. Okay? We only had one trial with very controversial results, and so it's again something that we should save because immunotherapy is very expensive and very toxic. And so other things should be your priority. And I think that's my last slide, showing some of the patient advocates with whom I've been working all these years and that have been an inspiration and help. And then maybe you can join me in Lisbon in November. Thank you. Sorry I went a little bit.
Dr. Cardoso, can I just, there was one extra question that a patient had around, if we can sort of cover it quite quickly, around TDM1, which some of you will know as Kadcyla, where there has been an argument put forward here to say that because the clinical trials didn't show didn't test TDM1 after pertuzumab or Perjeta, that there's no rationale to use it in the metastatic setting as a follow-on from Perjeta. What's your view?
So it's true that the majority of the trials of TDM1 were done when pertuzumab was not yet used, but they are not going to be repeated. And so we have to take our results as they are. And these TDM1 trials, and TDM1 was used after many lines of treatment, and it still improves survival. So, and besides, we have now a new generation of trials that is comparing new drugs, not TDM1, really new anti-HER2 drugs, and have as a comparator the TDM1. And in that comparator arm, you have the results of TDM1 after pertuzumab, and they remain very similar. And so this is the evidence we have, and obviously medicine is always evolving. So a trial is already old when the results come out, and you cannot demand that it's being repeated.